Although it's totally a physiology based topic, I know that when you go on reading the books, you find this topic is much boring, and many times what you see that after 1-2 hours you just say that okay, bye bye, I am not going to read again, I'll see sometimes later. But okay, I'll cover it up in a crispy manner. I'll try to make you understand what exactly it means is applied understanding of gas exchange or normalities. Now, okay, all of you know about the oxygen transport from air to the tissues, how it happens, okay? Now, see, there are two units here. One is a lung unit, another is a kidney unit. So it is very clear from this picture that lung is the very simple kind of structure and kidney looks like a very complicated kind of structure. Now, what do you say? That the function of the kidney, managing a function of the kidney is more difficult, or managing the lung is more difficult? Why it is so?
Both are equal.
Okay, we'll come to that later on. But first of all, you see that, okay, here is the difference as far as the overall picture of an alveoli is concerned and a picture of nephron is concerned. So this is a small basic sample of a unit, or you can call it as an alveoli, and it shows the gas exchanges which takes place around this. The lung has got only two things to do. One is that it carries the oxygen from one side to other side and takes off the carbon dioxide from the tissue side to the alveolar side. So this is how it works. Okay. In normal subjects, if you see the tidal volume, it is 500 ml. So when the respiratory rate is 15, the minute volume will be 7,500. We exclude the dead space. The effective alveolar ventilation comes to around 5 to 50 ml. The functional residual capacity is 3000 ml. So when you divide this alveolar ventilation with the pulmonary capillary blood flow, which is around 70 ml per minute, that gives rise to ventilation perfusion ratio. And that is ventilation perfusion ratio is 1. Here it is calculated. Now, again another question. Why the God has made our lung like that? That it has to pass through one tube, then it goes to an alveoli, and it comes to the alveolar capillary membrane, then it goes to the blood, and finally it goes to the circulation. Why he has not made it more simple, like a gill of a fish? If you see the gill of a fish, what is the difference between gill of a fish and the human lung? Can somebody tell me? Capacity, that is the reserve volume which works whenever you go and dive inside some inside a pond or any water reservoir. Okay, so you can continue with the apneic state for not less than 3 minutes. You can try it for 3 minutes, but with practice it can go up to much more level. Now, this is a perfect lung model. I'm not talking about a normal lung. It is a perfect lung. Okay, so perfect lung, what do you expect from a perfect lung? It takes the air. Air comes at a pressure of 150 millimeters of mercury inside the trachea. How it calculated? It is calculated from the atmospheric pressure of 760 millimeters of mercury. You reduce the atmospheric atmospheric water from that, and you reduce the nitrogen pressure, and this 150 millimeters of mercury is the pressure of air which goes inside the lung. And when it is carried to the level of alveoli, the pressure comes down to 100 millimeters of mercury. It is 100. And then finally it goes through the tissues to the mitochondria. And when it goes to the mitochondria, the pressure is around 4 millimeters of mercury. So this is a model of a perfect lung which can think of. But it does not happen usually with human beings. This is an example just with, say, a patient who has got a respiratory center depression, who has got a damaged medulla or some kind of nerve muscle disorder, injury of the chest wall, or any kind of obstruction in the upper airway. What happens? The patient hypoventilates. The patient hypoventilates. So hypoventilation means reduced alveolar ventilation. And reduced alveolar ventilation means there is a drastic drop in the oxygen level at the level of alveoli. So what you see at this here from 150, it is dropping down directly to 50 millimeters of mercury, and that is catastrophic. So what you need at this moment is that you need to supplement oxygen to your patient. Okay? Now we talk about normal lung. Normal lung differs from a perfect lung in three respects. We all have got small defects with our normal mechanism function. One is the diffusion defect. There is a small amount of shunt going on in every one of us, and there is a defect of ventilation perfusion ratio inequality. So diffusion, shunt, and ventilation perfusion ratio inequality, these three exist in every one of us. Although all these conditions get precipitated by various kinds of diseases. So in normal lung, although it is present, but their contribution in arterial hypoxemia is barely measurable. Now, you look at this diagram. The way it happens, it shows a pulmonary capillary transit time. The blood is flowing, this capillary, from here. The time of the capillary, the blood flows from here to here. And during its transport, the capillary blood has got a partial pressure of oxygen of 40. And once it crosses through the alveoli, it takes the oxygen, with the partial pressure of which is at the level of alveoli is 100. Once it crosses through it, it almost reaches the level which is there in the alveoli. So it tries to attain the same partial pressure which is there in the alveoli. Okay? Now we'll see what happens with the diffusion defect. Diffusion defects normally we find when we call it as in a disease state. But normally also it is present in the lung, but in disease states like diffuse interstitial fibrosis, sarcoidosis, asbestosis, alveolar carcinomatosis, all these gives rise to some kind of diffusion defect. So in diffusion defect, again what happens, this is called an oxygen transport or oxygen line which is drawn from 150 to the tissues. There is a drop, initial drop at the level of alveoli, and then again because of diffusion defect there is again another drop over here. Now, you see this slide. Suppose the patient becomes hypoxic because of some reason. So what happens is the alveolar gas pressure becomes 50 at the level of alveoli. And the venous blood which is coming to the alveoli to carry blood from oxygenated blood from here, as it gets transmitted, it carries less oxygen because the gradient pressure, there the gradient pressure was between 140, that is 60 millimeters of mercury. Here the gradient pressure is only 30 millimeters of mercury. 50 minus 20, that is 30 millimeters of mercury. So amount of oxygen which is carried during transit in a patient who is hypoxic is less as compared to normal patients. So there is a huge difference between alveoli and capillary at this level as compared to the previous diagram. If this kind of patient undergoes any kind of exercise, or suppose a patient who has got some kind of problem in the lung and is admitted in your ICU, and you are not giving oxygen, and in the meantime you are providing with physiotherapy. So what happens? That physiotherapy increases the capillary transit time. It increases the heart rate. By virtue of that, it increases the capillary transit time through the alveolar capillaries, which carries less oxygen. So patient becomes immediately hypoxic. So that is why what is required is that always supplement oxygen whenever a patient with some kind of disease in the lung is undergoing physiotherapy inside your ICU. Now this is a perfect lung model modified to show depression blood. So another thing which I shown in my previous slide was that a shunt effect. So in shunt, the conditions which can give rise to shunt effect are normally the disease conditions are tetralogy of Fallot, ASD, VSD, then pulmonary atelectasis, pulmonary edema, abnormal pulmonary arteriovenous connections. All these conditions give rise to shunt effect. But normally also it is present in between the bronchial vessels, in between the pulmonary artery and capillaries, and also Thebetian vessels which happens in the heart. So again there is a drop down in the PO2 line, and the final the PO2 which comes out is around 97 millimeters of mercury. Now this is the major problem which happens in any lung. Although the ventilation perfusion defect exists with us, small little bit of ventilation perfusion defect is there with each of us. But in disease state, what happens? This is the most common problem which happens, and that is the ventilation perfusion ratio inequality. So you can see that it is just a diagrammatic representation how the things changes. There is an alveoli here, there is an alveoli here. The blood is carried from these two alveoli and finally it comes to form a mixed capillary alveolar blood, and then it goes to the arterial and finally goes to the tissues. So there is a mixing of blood from various regions of the blood with different kind of ventilation perfusion mismatch. We'll go into the detail of this ventilation perfusion mismatch as we go beyond with our slides. Now we go to the inequality of blood flow and ventilation in the normal lung. This is the second thing which I am going to discuss. You see, the lung behaves like a container. So when you are standing, the maximum blood is at the lower and mid zone of the lung. When you are lying down, most of the blood is in the posterior part of the lung. When you are in prone position, most of the blood is in the anterior part. And when you are head down position, most of the blood comes to the upper part of the lung. So that is how the lung behaves like a container. Also, you'll see in a patient who has got ventricular septal defect, there is a shift much more of blood. Usually the hypoxic or the less ventilated area, the upper part of the lung is less ventilated. So in a patients with VSD or in a patients with pulmonary artery hypertension or in a patient where you can see that left ventricular failure is there, in those conditions because of some kind of mitral stenosis or so, what happens? The venous pressure or the engorgement due to blood vessels and the blood flow increases in the lung and it gets more uniformly distributed all over. Now all of you must be familiar with this diagram. This is the West zones of lung, has been classified in three forms, that is the three parts, that is upper, middle and lower. The upper part shows that the alveolar pressure is more than arterial pressure, and again arterial pressure is more than pulmonary venous pressure. Zone 2 shows that arterial pressure is more than alveolar pressure and that is more than venous pressure, and zone 3 shows that arteriovenous pressure difference is more than pulmonary alveolar pressure. Now if you see the blood flow in the normal upright lung, you see that this curve of blood flow is much more steeper as compared to the distribution of ventilation in the upright lung of a human C. So this curve is more steeper and this falls very gradually. So although the ventilation doesn't fall steadily as the perfusion, here you can see that this is the point of first rib and this is the upper zone. So you can very well differentiate the changes which happens from below the level of the lung to the apex of the lung, the change in ventilation perfusion ratio. So when we draw these two lines, one is a steeper line which was drawn by the blood flow and another line because of ventilation. So blood flow line is more steeper and this is less inclined. So what we do is that we derive ventilation perfusion ratio at each level of the lung. Now this is the line which gets developed after this is the ventilation perfusion ratio. So if you see, the change in ventilation perfusion ratio increases as we go up in the lung. Now, ventilation perfusion ratio inequality and regional gas exchange. This is a beaker where we are putting some amount of dye and there is a stirrer which is mixing the dye with the whatever solution it is, and in the bottom there is a pipe which carries water from that side. So ultimately the constitution or the concentration of the dye inside the vessel will be determined by the amount of powdered dye which is poured and the flow which is guided, the water which carries this dye from here. So it will depend both on the powdered dye, that the rate which is coming inside the beaker and the rate of flow of water from here. So final concentration is decided by these two. In that way, the lungs also decides the concentration of oxygen and carbon dioxide inside it. Now, you see that this is the extremes of ventilation perfusion ratio. On the one side, you see that the total ventilation is blocked, and on the other side, the total perfusion is also blocked. Now, when we see, when we draw a line on this side, it represents the tracheal level, and this side, it represents the mixed venous level. Now, when we make a diagram, it forms an oxygen carbon dioxide diagram, and that represents the ventilation perfusion ratio line. From here, this comes, this is the a level where there is a mixed venous blood is there, and here that's a completely oxygenated blood that is at a very high concentration, but there is no perfusion. Okay, now on the one side there is a decreased ventilation perfusion, and another side there is an increase in ventilation perfusion. Now when we put the lungs on this oxygen carbon dioxide diagram, what happens? The lungs is divided into 9 segments depending upon the oxygen and carbon dioxide perfusion which takes place. So when we put this lung slices in this oxygen carbon dioxide diagram, you can see that it very well accommodates in the middle part of it, and this is the mixed venous end, and this is the tracheal end where the ventilation perfusion ratio is high, and this side ventilation perfusion is extremely low. So the lung slices comes in between. Now the effect of change is ventilation perfusion ratio of the lung on the regional composition of alveolar gas. When we see the volume of lung also changes from top to bottom. Here you see that volume is nearly 7%. Here the volume of the lung is 13%. When we calculate the PO2 and PCO2, the difference is quite enormous. From 89 to 132, there is a difference of nearly 40 millimeters of mercury. But PCO2 difference from upper zone to lower zone is nearly 14 millimeters of mercury. Similarly, you can always calculate by subtracting the oxygen and nitrogen, oxygen and carbon dioxide. You can calculate the partial pressure of nitrogen. This is oxygen dissociation curve. What happens with the increase in partial pressure of carbon dioxide? When the carbon dioxide goes higher towards the curve shifts to the right. So when the PO2 is high, the dissociation curve becomes flat, and that the PCO2 is increased, the curve shifts to the right, so that for a given PO2, the blood holds less oxygen. The affinity for oxygen to hemoglobin reduces, and that helps in the delivery of oxygen at the peripheral level, and this is called a Bohr effect. Another thing is that Halden effect, which helps, and these curves are more straighter as compared to that oxygen dissociation curve. What happens because of this effect? The carriage of carbon dioxide from the capillaries to the from the tissues to the capillaries increases. Okay. Now we combine these two curves on the again oxygen carbon dioxide diagram, and on that, with that you see that on the one side you can see the volume percent of carbon dioxide, on the other side the percent pressure of carbon dioxide, and here the partial pressure of oxygen on this side. So you combine this oxygen dissociation curve as well as carbon dioxide dissociation curve, and finally you can calculate if the patient's carbon dioxide volume percent at particular level as well as oxygen content and PCO2. Now with that, here we see that we have been able to calculate the level of oxygen in and carbon dioxide as well as nitrogen, and finally this is the respiratory exchange ratio. Respiratory exchange ratio lines are derived when the carbon dioxide goes out into the alveoli, the amount of carbon dioxide which is released and the amount of oxygen which is taken up by the capillaries, that forms the gas R lines. And these R lines are starts from infinity, and that goes straight away in this inclined manner towards the mixed venous side and towards the tracheal side. So there is a range of factors which you take from these gas R lines, and similarly these blood R lines are also calculated by this. That means the amount of blood, the amount of oxygen which is taken up by the blood in the capillaries in the alveoli, and the amount of carbon dioxide which is released to the alveolus. And through that ratio, again you calculate these blood R lines. So gas R lines and blood R lines, and they crosses each other at the same level in oxygen carbon dioxide diagram. Now there are another things which also matter. One is that the compliance of the lung. If a lung is normally compliant, then what happens that during inspiration there is a fine inflation, there is a steady state upward stroke of the curve, and then it goes down gradually with the deflation of the lung, but if there is a low compliance, the lung inflates very sharply, and if there is a high airway resistance, the lung inflates very slowly. So these are those another factors which also determines the ventilation perfusion in any lung. Then this is another situation where we see that terminal bronchioles or terminal airways gets dilated, and what happens, the diffusion which happens here uniformly does not take at this place, so diffusion takes place in an abnormal manner. Now when we see that ventilation perfusion inequality and overall gas exchange, we calculate the ventilation alveolar partial pressure of alveolar and arterial oxygen tension difference, and we see that with this combining all this, when we calculate, it comes to around 4 millimeters of mercury. When we see it for carbon dioxide, it is 1 millimeter of mercury, and when we see it for nitrogen, it is nearly 3 millimeters of mercury. So the mixed venous blood carries a oxygen which is at a partial pressure of 97 millimeters of mercury. Now ideal alveolar gas should have a point of ventilation perfusion at this level. This side is the arterial line and this side is the venous line. This is the alveolar. If the point slides toward this side, that means there is more dead space ventilation, and if this point moves toward this side, that means there is more dead space perfusion. So the normal is 0.8. Now we'll see in various conditions what happens in a patient who has got pulmonary hypotension. What happens, that gas exchange in this upper zone is totally unperfused, so the alveolar line shifts to this side. Now what we do is that we calculate the oxygen carbon dioxide alveolar and arterial difference. Then we find that there is a difference of 20 millimeters of mercury of oxygen, and there is a 13 millimeters of difference in carbon dioxide. Now similarly, in a patient where we find that the lower level of the lung, means lower part of the lung is getting less ventilation, in patients with post-surgical prolonged anesthesia or bronchial secretion, or those patients who are having pulmonary edema or inhaled liquids. Here also you see that there is an alveolar arterial difference of oxygen at around 53 millimeters of mercury. When we calculate the distance of this line and you compare with this line, then you will find this. And similarly for carbon dioxide, you see the vertical distance between these two, and we can determine this. Now this is another example where both upper part is getting less perfusion and lower part is getting less ventilation, and there is a huge difference, means a generalized lung disease where these lines shift to a markedly huge distance, and at that time there is a huge alveolar and arterial oxygen and carbon dioxide difference you can see. Now this is a slide which suggests that there is a mechanism. In the morning Dr. Pinsky was saying that there is a mechanism actually that is of hypoxic pulmonary vasoconstriction as well as hypoxic vasoconstriction of the vessels in the kidney. These are the two organs where actually vasoconstriction takes place during crisis. Rest all other organ dilates. So here also what happens in extremes of situations, what happens, there is a hypoxic pulmonary vasoconstriction, and that is a protective mechanism. So finally what happens, this upper part and this lower part, they stop taking part in the gas exchange of the entire lung, and finally what happens, there is no displacement of the alveolar and arterial point, and the patient remains same with as far as ventilation perfusion ratio inequality is concerned. So finally, how to differentiate between ventilation perfusion mismatch from other causes of hypoxemia? In patients who are having shunt, if you give oxygen, there is no improvement. Effects of breathing low oxygen mixture that may differentiate diffusion abnormality or VQ mismatch. The association of raised arterial partial pressure of carbon dioxide. It can happen with hypoventilation. Impaired diffusion, it usually remains normal or low. In shunt effect, it usually remains normal. In ventilation perfusion abnormality is normal, high, low, or usually high. Effects of exercise, all four conditions will get worsens. So that is how you differentiate with the other condition. So most important is the ventilation perfusion mismatch which happens, and diagrammatically I have shown that how it affects the lung or the body physiology in various disease states. And if you understand this, I think when you go on bedside and manage your patients, if this concept stays with you, then you can always think of what kind of therapy exactly you need to give to your patient. Thank you.